Thank you. Okay, so indicators of circulation, hypertension is a late feature, but conscious level, if they are agitated, they can be hypoxic, they can be hypotensive. Peripheries, urine output, and blood gas for acidosis and lactate levels. And management will depend on the cause. So we have to identify the type of shock, whether it's like hypovolemic or cardiogenic or distributed, and management will depend on the cause. So mainstay is like fluid resuscitation and if needed, and vasopressors. It is a long topic I can't cover at the given time. Then disability. So what is the aim? Disability assessment. Just see the cerebral function. So I know brain is important. We got our neurologist in front, but brain depends on ABC as well. So if there is no airway patency, cerebral function is gone. If there is no adequate oxygenation from lungs, brain function is gone. If no blood delivery to brain, again brain function is impaired. So when we are resuscitating brain, it comes ABC plus brain. So make sure you get your ABCs corrected. Then you assess the cerebral function with GCS and ABPU. I know GCS is a bit long one, but we should be able to, each and every doctor should be able to assess GCS. So this is GCS, very important to know. And in case like if you can't remember, go by ABPU as well. So ABPU alert, verbal response, responding. So if patient is alert, it means GCS is 15. If responding just for verbal stimuli, it's like 13 to 14. If responding only to pain, it's around 8. If unresponsive, it's 3. And pupils, you look for bilateral pupil size and whether it's reactive or not. So why this unequal pupil is important? So if with transtentorial herniation, there will be compression at midbrain point. So third cranial nerve arises from midbrain. The parasympathetic fibers get compressed, so it will cause unequal pupils. One side will be dilated because of the compression on parasympathetic. So that is why we look for pupils. Then movements of all four limbs, especially with regard to trauma, I have to say, because sometimes we intubate these patients and neurosurgical team, they have no idea whether this patient has been moving all four limbs, and we can't say anything about spinal trauma. Major trauma patients, very important. I know it's very hard at that time, but keep an eye where the patient is moving all four limbs and just document. That is the only savior to the NSU team sometimes, because we have intubated given paralytics and they have no clue. So very important to just to have a look. And DEFG, what is DEFG? Yeah, there you go. So don't ever forget glucose. Very important, because sometimes it's just hypoglycemia coming with these kind of all presentations. So don't ever forget glucose. Very important to assess at the time of disability assessment, because cerebral function depends on the energy. So we need glucose. Okay, so the last thing is exposure. So exposure is kind of every other thing. You expose the patient, but make sure patient's dignity is maintained. You measure the temperature. You examine the abdomen. Don't forget the abdomen. Sometimes these septic patients, they can land in medical wards, but having some surgical pathology like biliary pathology leading to sepsis. So just make sure you check the abdomen, check for skin sepsis. They can be having a pneumonia gangrene. In wards we might miss. Right? So look for skin sepsis, examine the back. Just do an overall complete assessment that is done covered by exposure. So after the aimed examination, like initial stabilization, we follow MMR. It is measure, monitor, and reassess. So measure, you measure CBS, ECG, BBG, ultrasound, and urine output. These all, everything is like bedside, because we won't be getting any full blood count or anything. So everything can be done at bedside. Make sure you get an ECG for each and every critical inpatient. You do a blood gas, because we have to identify some respiratory compromise or circulatory compromise. Ultrasound scan is very important. I think actually we have to do a separate workshop on this with regard to ultrasound at bedside, very important to both setup. And urine output is a great indicator of circulation. And monitor, very important. Whenever a critically ill patient, just put
Just put it.
at the first instance. All three monitors at the first instance, ECG, pulse oximeter, and blood pressure. Just three. Get them on the monitor and ask the nurses to chart, because it's very important to get that first readings and to see how these patients are going, whether they are improving or whether they are going down the hill, and reassess. So it's important to reassess to see whether patient has responded to our treatment, and to see whether patients are deteriorating. Sometimes at the middle, when you assess in circulation, patients might struggle with breathing. Then you don't jump into B, you jump into A. Whenever a patient gets deteriorated during your initial assessment, you start from A and go back to your basics. Yes, so once you have identified the deteriorated pathology and physiology, deteriorated physiology and fix it, then you find the pathology, what led to this. So that is done with this directed history and examination. So now this patient is not dying, we have stabilized, we have given oxygen, sometimes it may be a BiPAP, maybe noradrenaline, we have stabilized. Then you go for directed history and examination to find the cause. Then you can identify the specific treatment when you identify the cause. Can be a sepsis, can be like a hemorrhagic shock with a splenic rupture, we never know. And ongoing care and handover. I want to highlight this handover part because I find it bit deficient in all units, including my own unit. So the standard of handing over is S bar. We call it the mnemonic S bar. So we give the situation, background, assessment, and recommendation. Trust me, when it's come to emergency patient like a trauma or anything, when you are telling the boss, we are having a very limited attention span. We are also like tick, 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 tick kind of. So you give the situation. When you are informing, sir, I'm talking about a patient with hemorrhagic shock, possibly due to a splenic rupture or following RT. So then we are getting a picture. Okay, this is the kind of thing I'm going to listen. Then you give the background. So this patient came with this RTA, this story you give. Then assessment. So ARA, breathing, circulation, the positive findings you found. Even a septic patient, you say like, sir, we are managing a septic shock patient due to pneumonia. Background is coming with fever for 3 days with purulent cough and so, diabetic, this. Then assessment, how bad is the respiration, initial saturation, what treatment we have done, and how is he going? Like whether he's improving or whether he is deteriorating. We are started on high flow, not responding, going into NIV, sort of. Then why you are calling? Because you are asking for opinion or you are going to inform. So I'm calling to inform you regarding this patient, or if you need opinion, sir, I need opinion whether to go for intubation. So it's very short and sweet. Because trust me, we don't remember most of the things you say unless you say in a structured manner. Don't go to the town, just follow the SPA. It's very easy, right? Okay, so in summary, follow the ABCD approach. I know it's a broad topic, but I wanted to highlight the principles of identifying the airway problems, breathing, what things to be looked into, circulation to look for the perfusion, disability, how to resuscitate the brain, and exposure. Then once you stabilize, do a complete examination and reassess. Treat the life-threatening problems first. First save the life, then find the cause. It's very important. Sometimes we miss that. Call for help early. If you are a SHO, you need help, just call your boss. Nobody will blame you for calling and informing about a critically ill patient. So make sure if you are informing, it means that you are concerned about the patient, which we really appreciate. So just inform your boss, right? And very important, effective teamwork, because emergency you can't manage single-handedly. It's always teamwork. When I say teamwork, it's not just doctors, get your nurses, get your minor staffing, because sometimes we need to send these patients urgently to the theater and sort of. So just maintain effective teamwork. Have you got any questions? Any personal experiences, anything you encountered? If no questions, we will move into this video, which will show a nice summary of what we discussed on how to assess a critically ill patient. And if you get any questions, meanwhile, you can ask me afterwards, okay?
Like another service of your observations. I'm going to speak to one of the doctors about on the telephone. I'm going to give you a call back here. If you need me at all, just press the button. You're there. I'll only be gone a moment. Is that okay?
Just listen how we will be
Yes, I'm the registrar.
informing.
Yes, that's what we do for you.
Hi there. I'm a staff nurse on 10. I want to talk to you about a patient who's got a new score of 9.
Yeah, go ahead.
Yeah, it's a patient that was admitted with abdominal pain and vomiting. It's got a respiratory rate of 25 with a saturation of 92 on air. It's got a heart rate of 120 with a blood pressure of 105/50. Also a temperature of 38.5. I wonder if you can come and see him for me.
Yeah, he sounds pretty sick. I'll be up straight away. Can you do me a favour? In the end of 2 minutes, get to speak with him, please.
Certainly, will do.
Hi, Michael. My name's Adam. I'm one of the doctors. So if I call you Michael? Okay, how are you feeling?
Off.
Okay, yeah, you're not looking too good. Okay, I just need to do an assessment on you to see how you're doing and getting on. Map of his airway. If we get some oxygen on him, high flow, 15 litres, please, non-breathe, breathe. It's a bit concerning. It's really hard to breathe. Could you also put a sat probe on as well, please, and check his respiratory rate? I'm just going to check your respiratory function, airway and breathing. Trachea is central. Can you take a deep breath in for me, please? Okay, so it's got good equal chest expansion. I'm just going to tap your chest so this is okay. How it sounds. Okay, there is equal resonance there. Mike, we're going to have a quick listen to your chest as well. Nice form of body. Be able to sit up a bit, Michael. I'm just going to quick listen to your back. See you back. It's got feeling there, actually, now it sounds there. So just reassurance to be combined. What's the saturation doing?
Saturations are 95 on the oxygen.
That's the problem. Respiratory rate is really well there. We move on to circulation. His breathing. Can you check his pulse and his blood pressure for me, please? I see your name then as well. 1, 2, 3, 4, 5. So it comes back pretty quickly. No signs of dehydration. Well, very warm. It's got a bit listening to your chest there. It's your heart. Okay, your heart's quite fast there, but there's no added sounds. It's 120, okay. 120, okay. Do we have a blood pressure yet? Most no. Could we get on a heart monitor? Because I'm a bit concerned. You know, he's very warm, he's got high fast heart rates. Well, I think we should put on a cardiac monitor. How's his urine output been doing, Bill?
He's been self-voiding. We did stick to the sample that he was positive for protein and leukocytes.
Okay, so he's brewing a bit of a urinary infection, we're seeing here. Hi, thank you for coming. I'm really quite concerned that Michael Weir's got sepsis from a urinary background here. Can you put a cannula in for, please, and take some bloods? Can we get the FPCs, using these? Can we get a CRP? Can we get the blood cultures that group can say? And can we also take a bit of blood for blood sugar as well, please? And let me know when that's done. When we've got that cannula, we can get a bag of 500 ml for the same one, please. For the stats, and can get some IV antibiotics as well. We put in architects while we get that fluid attached. Michael, just going to check your local serology there. How are you feeling at the moment? Oh, okay, so you're responding to voice there. Okay, the size 4 equal responsive to light. Just going to assess your abdomen or stomach and see how you're doing. Have you got any pain down there at all? And don't feel any pain at all? Okay, I'm just going to check and feel how your kidneys are doing. Okay, so after those supplements, and we do have some loin pain. I'm just going to check, see if there's anything I'm missing. Okay, just expose you. Okay, no signs of rashes, no bleeding.
That's your 7.2 and I take it plus.
Great, thank you. Yeah, come on, this is urgent. Please get sent off. You're able to get a temperature for me there, please, Bill. So, thank you. Okay, so I really think it's just a sepsis here. Michael, you've got quite a severe infection here. So I'm going to contact the ITU doctors to come down and assess you. And we're starting on some IV fluids, we're getting antibiotics into you as well. I'm going to take another blood sample from you. We need to put a urinary catheter in. Do you know what one of those is? Okay, yeah, can you take a blood gas? We can see what lactate's doing. We're going to urgently. Bill, can you set up for a urinary catheter as well and put that in? So I'll let know there's fluids through. I'm going to speak to ITU and get them to come down and assess urgently and speak to my seniors as well and let them know what's going on with mine. So I'm really quite concerned.
It was quite a summary, isn't it? So in that video, you could see like how the nurse informed the doctor, the summary quite nicely given to the like point form. Then this doctor gave some advices before arrival, especially when you are doing night on call, just give some advices to the
Few friends.
before
Supported along the way. I want to.
just give some advices like start fluids, get cannulas and sort of. And when you arrive, just don't panic, call for help, just start assessing immediately. You could see like how nicely he did, start getting on monitor, start on oxygen, assess and look for the cause, like deterioration of the physiology in each component and fix it. Then go for the diagnosis, like at the end only he said like, okay, it's sepsis during the morning. But first he gave oxygen, he got cannulas, he started fluids, gave antibiotics, and then ultimately he went for the diagnosis. So that's the art of managing a critical need patient. Right, so I hope from here, we were here, at the beginning we were here, right? Yeah, so I hope from here we have come over to here. Am I correct? No? I hope so. So just, I would say, if you see a sick patient, don't run away because you feel that. Especially when I started this training, I saw a call when you are dealing emergency. Initially, you will feel running away because you don't know. But train yourself up to a level where you feel like running towards the patients because you know you are the best person for the patient. So everybody is capable of, because this is very basic. We are not good at hi-fi stuff. They are there for that. I am not good with hi-fi stuff, but basics everybody can do. Okay. All right. So thank you for your attention.